Okay, I think we'll give it just a few more minutes as people filter into our virtual room here. It is 7:04, so I think we'll wait until 7:05 and get cracking. All right, I am seeing pictures on the screen of Taryn and Julia's name. I don't know if anybody else is seeing that. Okay. All right. Well, let's get cracking. Good evening, everybody, and welcome to tonight's event, which is anticoagulation and reversal agents. We are super excited for this topic. I know it is a major topic for the patient community, and here we go. So we have a great discussion planned for tonight, but before we get going, we want to introduce our clinical guest. And so we have with us Dr. Daniel Witt. Dan is a tenured professor and chair of the Department of Pharmacotherapy at the University of Utah College of Pharmacy. He received his BS degree in pharmacy from the University of Utah and the PHARMD degree from the University of Washington. He completed a clinical pharmacy residency at the University of Washington and Harborview Medical Center in Seattle, Washington, and an advanced residency in primary care and family medicine, University of Washington. Dan has authored, and I was absolutely blown away by this, or co-authored over 100 journal articles, 11 book chapters, and given numerous lectures for continuing education programs. His research interests center on providing practical information regarding the optimal use of anticoagulation therapy to frontline practitioners and patients. He was a panel member for the 2012 CHEST Consensus Guidelines for Antithrombotic Therapy, and is chair and a panel member for Venous Thromboembolism Guidelines developed by the American Society of Hematology. Dan also serves on the Medical and Scientific Advisory Board of the National Blood Clot Alliance and is a member of the American College of Clinical Pharmacy, American Society of Health Systems Pharmacists, and the International Society on Thrombosis and Hemostasis. Dan, we are so delighted to have you here tonight. This is very exciting for us, and we want to thank you for your participation this evening. So before we get started, though, we are going to hand it over to Todd, who's going to lead us through some poll questions. Todd?
Okay, thanks, Leslie. And Dan, thank you for being here. Look forward to talking to you tonight. Okay, folks, we've got a poll. You know how this works. I want you to go ahead and answer these questions. It'll take just a quick second, and then we're going to review. Our first question: what anticoagulant, also known as a blood thinner, are you on? So you see your selections there. They include Eliquis, Pradaxa, Xarelto. If you can mark down what you're on, that would be great so we can get an idea of who's on what. Our second question: how much do you know about anticoagulant reversal agents? Are you very knowledgeable or some knowledge? And is that the last one? Oh, I'm not very knowledgeable. I'm sorry, I had to scroll down. So very knowledgeable, some knowledge, not very knowledgeable on what you know about reversal agents. So go ahead and answer those questions, and then we'll go ahead and discuss the results. All right, so there you see some results for the anticoagulants. Yeah, I mean, I'm just looking at some, and we see warfarin, 18%, Eliquis, 42%. That's one of the most popular DOACs out there. Lovenox, Pradaxa, 0%. That one's not as much in use as I think it used to be. And Xarelto, 27%. So it looks like a lot of people on Eliquis. I'm on Xarelto myself. And then the other question, let's see, how much do you know about anticoagulant reversal agents? Only 4% are very knowledgeable, 31% have some knowledge, and 65% not very knowledgeable at all. We hope to change that tonight, and we are very thankful that Dan's here. So thank you, folks, for answering the poll questions. Leslie, back to you.
Thanks. Okay, so before we get going, we want to just remind everyone that this is an educational event only. We are actually not here to give medical advice or replace your doctor. So if you do have questions, please connect directly with your own physician. And with that, I know, Dan, you have some slides that you're going to be showing tonight as well. But we thought we would start out with, while the topic is about reversal agents, We thought perhaps we take a step back and have you just discuss anticoagulants overall, so that it would lead us up to the reversal discussion. So what are the different types? How long do they last in your body? How do they actually work? Do they each work differently? And why are they actually called blood thinners? Because if they don't actually thin the blood, how did they get this name? So these are a lot of the questions that don't get answered in a clinical setting. So we'd like you to help us with this.
Yes, well, thank you for inviting me to be here. I am very excited to be here and just love the opportunity to connect with people that are actually living with blood clotting and having to take anticoagulants, because I hopefully will be able to answer some questions and give you some more information that'll help you live a life that's that you feel comfortable with and is full, and answer any questions that you have. A lot of those questions, Leslie, or sorry, Ms. Lake.
I go by Leslie, that's okay.
Yeah, okay.
We're very informal here.
Right, I know. We had a little interaction earlier where she wanted to know if I wanted to be called Dr. Witt, and I said, no, that's fine. She said, well, please call me Ms. Lake.
I was only kidding.
She was kidding. So I do have a few slides, and I think some of those questions that you asked will get covered on that. But if I don't cover everything, please, let's circle back around and talk about that so that people have a good feel for that. So as I share my slides, I know you guys, I didn't get a formal poll question on this, but I just want you to think to yourself. I'm asking you a question. There's going to be two pictures on there, and I'm going to use the term called thrombosis, which I think you guys are all familiar with. But there's also, thrombosis has a specific meaning, and then there's another term called hemostasis. So I didn't use the term hemostasis on the slide, but I want you guys to be thinking about, of these two pictures, which one seems to be saying to you, this is thrombosis versus hemostasis. And it's okay if you don't know the answer to that. Sometimes, it's good to ask questions that we don't know the answer to, because it helps focus our thinking as we start to move forward to the presentation, because you'll get this question answered. All right. Let's see. Did my slides come through?
Oh, there they are.
Okay. All right. So two images here. So just think to yourself, which one of these pictures is actually describing thrombosis? So the one on the left is that's my forearm following a mountain biking accident. And then the picture on the right is actually taken from the internet, but it's some pictures of some clots that were removed from a patient's lung. So the answer to the question is hemostasis refers to the very controlled process of arresting blood loss from an injured blood vessel. So we are all going to get injured at some point in time, right? Bleeding is something that happens frequently. It might happen when you're brushing your teeth. It might happen, you fall and hit your arm or something. There's a lot of ways that bleeding can occur. And hemostasis is that normally very controlled process that forms a blood clot right at the area of the injury and then stops. But thrombosis refers to the situation where we've got blood clotting going on in the wrong place. So if any of you are gardeners, a weed is just a plant that's growing in the wrong place, right? So a blood clot is just thrombosis is a blood clot that's formed in the wrong place. And usually, instead of a tightly controlled process where you just form enough blood clot to arrest the blood loss, you're going to form a lot of extra blood clot, and that's going to interfere with normal blood circulation. And it has the potential then to break off, a piece of that break off and can travel somewhere else in the body where it's going to actually even cause more problems, commonly into the lung or into the brain, to cause strokes. So just so that we've got that we're talking about, we often sort of illustrate how blood clots form when we're talking about the process of hemostasis, responding to injury. But just keep in mind that thrombosis is when that something goes wrong with that process so that things get out of control and out of bounds.
Okay.
So this is sort of a simplified diagram, and we're going to go from top to bottom of this very quickly. But I want you to understand, and I've got a picture to illustrate this, that these things are not happening very neatly in a sequence like this. It's like chaos, like all of these things are sort of happening at the same time for blood clots to form. But typically what happens is we get some sort of injury to the blood vessel wall. And the blood vessel wall is one of its primary functions is to keep the constituents of blood that are responsible for forming blood clots, which we're going to talk about here in just a second, away from the inner layers of that blood vessel. So when you injure yourself or those inner layers are exposed to circulating blood, the first thing that happens is blood gets exposed to von Willebrand factor and collagen and tissue factor. And it's not important that you know all of those things, but those are just things inside the deep layers of the blood vessel that when blood, specifically platelet, come in contact with them, a bunch of explosive events start to happen to try to form a blood clot to arrest that blood flow. So we get activation of platelets by these agents here, and we get what's known as a platelet thrombus, or a plug that is primarily composed of platelets, and that they start signaling to other constituents of the blood to say, hey, something bad is going on here, we need you to come help. And so this coagulation system is then activated, and that's mainly activated by this substance called tissue factor that is found inside the blood vessel walls. So there are a number of clotting factors that your body produces, mainly produced by your liver. And these things just sort of circulate around looking for trouble. And when they see these platelets starting to respond to an injury to the blood vessel wall, they're going to go there and start interacting one with each other. And they're going to kind of cascade. I've got a picture to show you this. And they're going to form a substance called thrombin. And so thrombin is a really key player in blood clot formation. And it's just activated factor 2. So we don't have it specifically labeled as factor 2, but that's what thrombin is activated factor 2. Now, thrombin takes a substance called fibrinogen that's circulating around in your blood as a soluble form, and it starts to cause a change in its structure. So all of a sudden it starts to become insoluble, and it starts to form these very sticky spider web-like strands. And they start to adhere to all those platelets that are formed, that plug there. And then they start to trap red blood cells and white blood cells and more platelets, and everybody gets involved here. And pretty soon you got this kind of sticky mass that's preventing blood loss from that area of damaged blood vessel wall. There's another factor here that takes all of those fibrin strands and sort of links them all together and cross-links them and makes them very stable. And so in a matter of seconds, you've sort of got this fibrin mesh network that is preventing blood loss from that injured area. And then as it starts to form, there's also things that are secreted from the cells that are nearby that haven't been damaged, because you don't want that blood clot to spread out and start to cause problems. So things like tissue plasminogen activator, these are like natural anticoagulant substances that are then going to start to dissolve that clot or prevent it from spreading where it's not needed. And then over time, your body is just going to dissolve that blood clot. And I think that was one of the questions that we got, is like, how do blood clots actually dissolve once they form in your body? And you have the natural ability to do that. So think of everything on the left side of this diagram as sort of the accelerator. If we have a car that has an accelerator, right? So this is going to cause things to move towards blood clotting and then blood clot dissolution.
And this process is happening very quickly.
Yeah. In just a few slides, or maybe even the next slide, I'm going to show you a picture of this. And it has some timestamps on there about how fast this actually occurs. Right. Now, everything on the right side of this, if you had a car that only had a gas pedal, you would not be able to control that car very well, right? And if you tried to drive down a windy road, you'd like end up into the guardrail. right? And so if we're going to have a well-ordered hemostatic process, right, that is only confined to the area, then we need substances that can kind of put the brakes on this process. So antithrombin, your body actually has a natural heparin-like substance that it secretes from blood cells in the vessel wall. Protein C, protein S, some of these, you might be familiar with some of those. And then these things are sort of brakes on the whole blood dissolution process. So the main thing I want you to take away from this is there are lots of actors here, right? There's lots of different components going on. So if there's no more questions, let's move on to the next slide here.
Okay.
So this like strikes fear into the hearts of pharmacy students and medical students. They have to try to memorize this, right? They're like, oh my gosh, I just can't remember this. And you don't have to remember it either. The main thing I just want to illustrate with this is the cascading nature of how blood clotting factors work. So there's two different pathways referred to as the extrinsic and the intrinsic pathway. And it's mainly by this extrinsic pathway that blood clots form in your body. Right. So tissue factor, again, you get exposure to that when you get an injured blood vessel. And then on this intrinsic pathway, this is mainly when blood gets exposed to foreign surfaces. So if the reason that you're on blood anticoagulants because you have a mechanical heart valve, you got a piece of metal in your heart, right? Or maybe a blood clot formed in your body because you had an indwelling catheter, like a central catheter that, you were in the intensive care unit, or you had to have a PICC line in or something like that, but it's foreign material in your blood. And when blood comes in contact with this, it can start to form blood clots via this intrinsic pathway. And all of those things, you start with factor 11, it gets activated by factor 12 here, and then it activates factor 9, and working together with factor 8, it activates factor 10. And you can also get factor 10 activated by 7 and tissue factor here. And then you convert prothrombin or factor 2 into thrombin. And if you remember from the slide that we were just on, thrombin is like a really key molecule here. So when we start talking about how anticoagulants work, all of them are going to interfere with one or more of these blood clotting factors. They're either going to directly sort of block the action, or they're going to work in the liver to reduce the synthesis of normally functioning blood clotting factors. And we'll talk about that a little bit in subsequent slides.
Right.
Okay, move on to the next slide there, Leslie.
Yep, we're good.
Okay. All right, so here's the picture that I was talking about. So this is some really neat work that some researchers at Harvard have done. And so if you look really closely here, you can kind of see that there's a blood vessel there, and blood is actually flowing from right to left on this diagram. So what happens is that they use some sort of a instrument to cause an injury to the blood vessel right here, right? Now, this red color is highlighting the role of platelets. So you can see within 10 seconds, when you injure that blood vessel, all of a sudden you've got these platelets rushing to the scene. They're the first responders, right? And they start adhering and sticking to that injured area, and they just start releasing a whole bunch of stuff out of the platelets into the circulation there, saying, hey, more platelets, come and help us, and let's all stick together here to try to prevent blood from coming out of here. And then you can then start to see these other colors, like the green is tissue factor and the white is sort of everything combining in together, the blood clotting factors and forming fibrin and those types of things. But you can see it's just this mass of action, right? Everything's happening. And this blue color here, that's actually the fibrin clot starting to form. Whoops, let me go back. Or forward, actually. That's the fibrin clot starting to form right there. And so
this is fascinating.
Yeah, you can see that, here's a minute. So within a minute, you can see we've already got some fibrin clot sealing up that hole in the blood vessel. All right. And so within, 2 or 3 minutes here, we've got a stable fibrin clot that's forming there. And think about that in your own body, you know, when you cut yourself shaving, or, you know, you get a bloody nose or something like that. You know, you usually start to see things slow down usually within a few minutes, and maybe back before you started taking anticoagulant medications. Now, what the anticoagulant medicines are going to do is they're actually going to increase the time that it takes your blood to form that clot. So what we're trying to accomplish is a nice balance between preventing harmful blood clots like that thrombosis that we saw, right? The big clots that cause damage and can impair blood flow, from helpful blood clots like you need if you were to cut yourself or develop an ulcer in your stomach, or, you know, get a urinary tract infection and start to bleed into your bladder. So, you know, all of these are, you know, we're trying to get a good balance of those things. Now,
it's amazing how quickly this moves.
Yeah, it is. Now, a dangerous blood clot, you know, like those big blood clots we saw, and many of you may have experienced a blood clot in your leg, you know, that probably formed and then just grew and grew and grew. It could have been over hours or days or even weeks, right? And got big enough that it started to really cause symptoms, pain, swelling. If a piece of that broke off and traveled to your lung, right, then, you know, that's a medical emergency. I should let everybody know that on Christmas Day 2016, my dad, who was recovering in a nursing home after he fell and broke his hip, had a fatal pulmonary embolism. So in addition to, you know, this being the area that I've sort of spent most of my career working on, it hits home for my family and me, because, you know, we lost our dad to fatal pulmonary embolism.
We did not know that. We're very sorry.
Oh, well, thank you. Yeah. Okay, so why are they called blood thinners? Before I move off this slide, because
actually, before you move forward, can I just ask one question?
Sure.
So Todd and I will have this conversation sometimes, and we're both on Xarelto. I'm on a lower dosage than he is, but I have a tendency to bleed more often than he does. Is it different from person to person, the influence that it has on one's ability to bleed or clot, or combination thereof?
It just seems like, yeah, some people are just more aggressive to the bleeding than others. And it seems to be, you know, all over the board. Why is that?
Yeah, it's a great question. And I think biodiversity is one of the answers to that, is that, you know, everybody sort of has different levels of clotting factors in their blood. It's pretty well documented that women tend to have a lot more bleeding complications, especially on Xarelto, than men. And oftentimes that's related to, you know, a gynecological bleeding. So like heavy menstrual periods and things like that. But it's, for some reason in women, this mucosal type bleeding tends to happen more commonly than in men. And that might just be physiologic differences between women and men.
Thank you. Okay, sorry, we cut you off on
interrupt away. So these drugs actually don't cause your blood to be thinner, right? They just increase the amount of time that it takes to form a blood clot. I think it's sort of easier to explain or use a term like a blood thinning agent to get people to think about, oh, it's affecting my blood, right? And it's making it more likely that, you know, I won't form a blood clot because it's thinning out my blood. And I talk to people, probably not a week goes by where I don't hear somebody say, oh, you know, is this going to make me feel cold? Because I've felt a lot colder since I've been taking, you know, this warfarin or these medications. And, you know, physiologically, I don't have any reason to explain why that would be, but it's something that I hear repeatedly over and over again.
And that's in the support group a lot too, Dan.
Yeah.
You know, people are colder. It must be the DOAC, right? What about I'm losing my hair? It must be the DOAC, right? I mean, we hear a lot of that, and sometimes you feel helpless because even the doctors don't tell them that, well, that's directly related to the DOAC. It's like we don't know that. So, but it just shows you how complicated the human body is and all the mechanisms at work. I mean, what affects one person may not affect another.
For sure. And I don't ever say to somebody, oh, it's not the drug, you know, it's not that.
Right.
Who knows?
Who knows?
Like,
Who
we
knows?
don't know what all the side effects are. You know, drugs have effects. They don't cause one effect, they have effects, and you
Right.
know, they affect different people in different ways.
And somebody can have a side effect that's not listed on the side effects.
Absolutely.
Absolutely.
Yep. And the way we kind of track those down sometimes is, you know, report those to their different reporting mechanism with the FDA. And then, you know, if enough of those are reported, then we can like kind of try to nail it down. Now, sometimes, you know, you have to go off of the drug and see if the symptoms get better. And sometimes that's not a real option with, but you could switch from one, you know, DOAC to a different DOAC and see if, you know, if hair loss was occurring, if it seems to slow down, or, you know, if you were having a lot of bleeding on Xarelto and you switch to Eliquis, then, you know, we can try different things. Back in the olden days, when I first started my career, you know, we didn't have any options, right? There was warfarin and good old heparin, that not the Lovenox that we use now, right?
Right.
Now we got all kinds of different options.
So Dan, a couple of a question came in just because I mentioned the term DOAC, and I have a habit of doing that in the group also, trying to teach people the terminology. But and correct me if I'm wrong. I'm just going to give them the answer. DOAC is direct oral anticoagulant. So like Xarelto, like Eliquis, things like that. We just use DOAC for short.
Yep, that's it. It was, you know, as an aside, when those new drugs came out, we called them NOACs, because they were the new oral anticoagulants, right? And then people said, well, that's not a good acronym because like they're not going to be new forever. And then said, oh, well, let's call them novel oral anticoagulants. And then somebody said, well, let's call them target specific oral anticoagulants. So we were calling them SOACs for a while. And then, you know, finally, and if you read, you know, the medical literature, some people still call them NOACs. So you might see them referred to that or direct oral anticoagulants as well.
Right.
And actually, they haven't been around that long.
2010 is when the first one, Pradaxa, came on the market. Yeah.
And I think I was approved for Xarelto like right after it was approved by the FDA. I think that was 2011.
Yeah. Yep. It was the second one that came on the market. So I want to go back to this slide because I want to sort of like illustrate why they're called direct oral anticoagulant drugs. So remember, all of these different clotting factors are working together. Now, warfarin, which has been around for decades, you know, and we've used for years and years and years, it is more of a non-specific inhibitor of clotting factors. So it causes, it inhibits an enzyme in your liver that actually uses vitamin K to form these blood clotting factors. So mainly 2, 7, 9, and 10. So warfarin actually makes it so that your liver, you still churn out these clotting factors. It doesn't prevent your liver from making them, but they don't work as well. So they're sort of defective, if you will. So they only retain a part of their ability to form blood clots. Right. So warfarin affects at least 4 of these blood clotting factors. Now, the direct oral anticoagulants, right, they are very specifically target either 2, and that's Pradaxa. So it's a direct thrombin inhibitor, or 10, and that's sorry, I always talk about them in the generic terms, so I have to catch myself to refer to them by the brand name. So Eliquis, Pradaxa, and Xarelto, they specifically interfere with factor 10A. So they're called 10A inhibitors. But that's why they're called direct oral anticoagulants, because they directly affect the clotting factor, whereas warfarin is really affecting the liver enzyme, which results downstream from you producing dysfunctional clotting factors that then go on to produce the anticoagulant effect. And then when we talk about heparins like Lovenox or just the kind of heparin you get in the hospital, they're mainly targeting factor 10 and factor 2. The low molecular weight heparins like Lovenox, they're more targeted towards factor 10, whereas the heparin that you get infused in the hospital, targets both 2 and 10. But they do that indirectly. They don't directly affect that. They actually, again, work through an enzyme called antithrombin that is responsible for breaking down those clotting factors. And so they're sort of like, they make that enzyme antithrombin work a lot more efficiently.
So Dan, Xarelto and Eliquis are pretty similar, but I mean, one's twice a day, one, Xarelto's once a day, at least after the 21 days. Is there any significant difference between Eliquis and Xarelto?
Chemically, if you got down there, yeah, there are some differences. They exert their effect by the same way, but they stay in the body differing times. That's why one, it can be taken twice daily and one is once daily. They're eliminated from the body differently. So Xarelto is more dependent on your kidneys to eliminate the drug from the body, whereas Eliquis is sort of equally reliant on the kidney and the liver. And so that helps people that prescribe these drugs figure out which one might be the best. And, patients' preferences can factor into that. I talk to people all the time, and given a choice, I'll say, hey, your insurance covers both of these. Which one would you like? And they say, I don't think I can take a drug twice a day. I think I would prefer the once a day drug. If you look at the data from the clinical trials, there's some slight differences in the bleeding complications between the drugs. I mentioned one of the differences when we talked about how women tend to have a little bit more bleeding with Xarelto than apixaban. So, they work pretty much the same way. They have the same mechanism of action, but there are some subtle differences between the drugs.
Apixaban being Eliquis.
Oh yeah, sorry. There I go. I'm like lapsing into generic terms.
I think that's one of the reasons my doctor didn't want me on Eliquis was because I'm factor V Leiden homozygous, and he was like, it's going to be much more convenient and easier to do the once a day dosing instead of using Eliquis.
Yeah,
right.
I actually switched over, and I know there's clinically the Xarelto has a little bit higher bleeding numbers, but for me, it was just a lifestyle thing. It was a little bit easier. Dan, before we move forward in the presentation, I want to circle back to something, because we do get questions a lot about the role that the liver plays in all of this if they're on a DOAC. Can you possibly talk about how that all works? Because there is concern from the patient community long term, what that means if you're on a DOAC for decades potentially. What kind of impact does that have on the liver, if any?
So the drugs themselves are not known to be toxic to the liver. There are some drugs that are well known to be associated with toxicity to the liver, like they can actually injure your liver. These drugs have not been associated with any direct toxicity themselves. Other than Pradaxa, and there's another drug called Savasa, edoxaban, and I noticed nobody was taking that. I feel bad for those guys because it's a perfectly good drug. It just got to the dance way too late, right? And by the time it has not caught in the U.S. market. In Japan, it gets prescribed all the time. But anyway, so those drugs are mostly dependent on the kidneys. But for Xarelto and Eliquis, which are the main drugs that get used in the US, they both have a component of the liver breaking down the drug. So the way the drug sort of gets taken out of your body is, and this is true for a lot of drugs, is first your liver sort of breaks it down into different, breakdown products. And typically what that does is makes it more easy for your kidneys to eliminate them, right? And so liver function is important because it can impact whether or not the drugs are going to be broken down. So if somebody has pretty severe liver disease, then we tend to shy away from these drugs just because we don't measure a test of how much of the drug is in the body. We don't know, there's a risk that you might accumulate the drug. So, but they're not themselves, they're not going to hurt your liver.
Okay. Well, that's important for people to know. Okay. So let's move forward.
Yeah. So this is just a quick cartoon to just kind of like reemphasize everything we've talked about here. So you get this break. So here's the blood vessel wall, and you get an injury. These platelets come along, they bind to the collagen and the von Willebrand factor, they get activated, they get more platelets involved, and then this tissue factor gets exposed, and then the clotting factor is going to get in here, and then they're going to get activated. They're going to like get more platelets involved, and the net effect is you get this fibrin generation. And really, you're going to fill up that injured area with clot. And when it gets filled up to the top, then no more new stuff can get in there, and that's when the clotting is supposed to stop. But when you get thrombosis, right, it gets out of control, and you keep growing clot. So this is what it looks like. Right, I love this picture, because these are these are the fibrin strands, right? And all of these little kind of grayish looking things, those are the platelets. Some of them are activated. You can see they're kind of all splayed out like a starfish, and some of them are not activated. And then you got these red blood cells that are trapped in there, and white blood cells. But that's at a very molecular level, right? That's what this fibrin clotting looks like. So we've already sort of gone over this. We talked about how the different drugs sort of what they work on. A couple of things that I want to point out, though, is for dalteparin and enoxaparin, we don't use much Fragmin here in the U.S. We use mostly Lovenox, and this is what is referred to as a low molecular weight heparin. So you give yourself injections of this based on how much you weigh. And then, you know, we don't need to monitor the drug, but it's not taken orally. It's given by injection. And there are certain situations where it's a preferred drug over some of the oral options. Fondaparinux or Arixtra is a drug that it's very specific to 10A, but it doesn't get used much. And the main reason why is it's got this very slow offset of effect. And so the reason why the onset and offset of the effect become important is like if you should start to bleed. So we're finally getting to the actual topic of discussion, 35 minutes in. But if you should start to bleed, right, and first thing we want to do is stop the anticoagulant. And so if it wears off quickly, in many cases, that's enough, right, to allow medical teams to get the bleeding under control. So if a drug is going to wear off within, 12 to 24 hours, that may be all we need to like get the bleeding under control. So the drugs that are good for that are drugs like Lovenox, Pradaxa, Eliquis, Xarelto, the DOACs. They have a very quick onset and a very quick offset. And so those are beneficial, like when you're starting treatment and when you need to interrupt treatment, either because you need to have surgery or a colonoscopy or, a dental procedure or some other thing, because they wear off quick. But then when you start them back up again, they get back up to speed really quick. Now you contrast that with what goes on with warfarin. It affects many factors, like we said, but remember, the way it works is it actually affects the liver, who is manufacturing new blood clotting factors. Any blood clotting factors that were in existence before you started taking that dose of warfarin, they need to go away for the warfarin to really start to be able to do its stuff. And so warfarin, as opposed to 2 hours to be up and running, it takes 5 to 7 days. So if anybody's on the meeting today and they took warfarin right from the get-go to treat their blood clot, you had to take some Lovenox probably, or some heparin, in the hospital for 5 or 6 days until that warfarin could get up to full speed. And that's just because it's got a really slow onset of effect. And then if you stop warfarin, it's going to take about 4 to 5 days before your blood starts clotting normally again. So we need to take that into consideration if you should develop some bleeding. So reversal agents sort of become way more important with a drug like warfarin that wears off slowly versus drugs like the DOACs that wear off very quickly. So let me flip to the next slide and let's start talking about these reversal agents. Now, we have known for, decades that vitamin K is an antidote for warfarin. So if for those of you who are taking this drug, you know that if you go to the Christmas party and they've got some delicious spinach dip and you like overindulge, right? Next time you check your INR, if it's within the next 3 or 4 days, you might notice it's a little lower than it should have been, because the effect of that vitamin K, it overcomes how warfarin works, right? Remember, warfarin interferes with your liver's use of vitamin K to make clotting factors. So if you pump in a bunch of vitamin K, you can actually overwhelm the effect of the warfarin. And so that's why vitamin K works as a reversal agent for warfarin. And so it's very common that, if you end up with a really high INR for whatever reason, maybe you got an interacting drug or you got sick or, whatever, and your INR gets really high, normally 2 to 3, and now all of a sudden it's 6. You might have been encouraged to either eat some vitamin K containing foods or actually prescribed a pill of vitamin K to take, and that'll cause your INR to come back down so that your blood will clot more normally. So vitamin K has been an antidote for warfarin. Now, another thing that we can do, but that takes hours to work, right? It takes probably 12 to 24 hours to really exert its effect.
Mm-hmm.
If you're bleeding very badly, like say you're bleeding into your brain, you fell and hit your head, or you got a ulcer in your stomach that opens up and you're just losing a ton of blood, right? And it's actually to the point where your life is being threatened by this bleeding. And that's what everybody worries about when they're taking anticoagulant drugs, right? It's like, we need to make your blood clot right now. There's a product called 4-factor prothrombin concentrate complexes. That's what PCC stands for. But effectively what this is it's the blood clotting factors that aren't inhibited by the warfarin, right? And so you can just inject those into the bloodstream and it'll make your blood clot normally within, minutes. I've actually consulted in some, court cases that, where these drugs were used, and somebody's INR was higher than 10. They were given a dose of these PCCs, and 20 minutes later, it was 1.4.
That's
right?
amazing.
So it just like immediately dropped the number down there. And I think one of the questions that I saw earlier is, well, is there a risk for that causing blood clotting? And that is a risk, right? So when you're in a situation where if we don't do something, there's a potential that the bleeding could result in death. And then if we reverse the effect of their anticoagulant, they could have clotting complications. We got to make a decision about what's the most pressing problem. And then hopefully, if we use these drugs in a careful, judicious way, we're going to minimize any risk for blood clotting associated with that.
Hey, Dan, do they have to wait to get to the hospital to have this done? What if an accident happens, they have to take an ambulance ride and it's a half hour? Are the medics able to do any of this in the ambulance during the transport?
Great question. I wouldn't be surprised if, like in crash carts that would be available in like an ambulance or EMT situation, if they didn't have a syringe of vitamin K in there, that they could administer that. But keep in mind, that's not really going to take effect for 6 to 12 hours, right? But I don't think they routinely stock like Kcentra, the clotting factors. And I'm pretty sure maybe I dare you Sizumab or Praxbind here. They might, but I know they don't run around with Andexa in their crash carts because it's like $15,000 a dose.
It's not even in most hospitals.
No, there are some hospitals that don't carry it. And it's just, and that was, I think, a question that many of our listeners had, do all hospitals carry those? And I'll answer that question in just a sec. So let's talk about the DOACs. So when these drugs came on the market, one of the things that concerned a lot of people is these Praxbind and Andexa, they were not available. There were no reversal agents on these. And so early on, there was a lot of concern about, people having potentially fatal bleeding complications associated with these drugs because there were no reversal agents. And that got a lot of traction and activity in the press early on. When we've gone back and very carefully examined the data from hospitals and emergency departments, what really happened is that these drugs actually, you were less likely to have fatal or very life-threatening bleeding or the bad outcomes associated with those, even in the absence of reversal agents being available, simply because they wear off so much quicker. Remember, I told you that when we give you a dose of vitamin K, it's going to take 12 hours or so to really increase, make your blood clot normally. Remember, if we just stop your dose of Eliquis or Xarelto, your blood's going to start clotting normally in 12 hours. So in effect, we sort of got the same process without even having to give anything. And so these drugs have proven to be, the outcomes associated with major bleeding associated with these drugs tend to be better than it is with warfarin, even though we have we've had reversal agents for warfarin right from the get-go. And the reason is I think that, we have room for improvement within the healthcare industry at how well we reverse warfarin. Like I said, I've been called in as an expert witness in some malpractice suit cases, and oftentimes it revolves around the management of warfarin-related bleeding.
Interesting.
Is there anything new that's being developed on the reversal front, or is it pretty much what you see here is what is available to patients?
Before I answer that question, let me just make a comment. I think that the availability of these reversal agents, so Praxbind with dabigatran, and then the Andexxa, the fact that people that are taking these drugs know that they're available, and the fact that physicians and people in hospitals know that they're available, has just done a really great job of making us all feel a lot better, right? It's like, okay, if we need them, they're there. How frequently do they actually get used in the management of bleeding? Not that often, believe it or not, because most of the time they're not needed. Now, bleeding into the brain, right? I think that's a situation where they probably get used more than in other types of bleeding. And then people that need urgent surgery, right? So if you came in, and a really important question that they're going to ask you, if you notice you have a big black tarry stool, and hopefully we're reinforcing that if that ever happens to you, you need to go to the emergency room. Like, don't mess around, like get in there. And they go in there and says, oh, we need to get you to have a colonoscopy like within 2 hours, right? Well, the first thing that they're going to ask you is, when did you take your last dose of your anticoagulant drug, right? And keep in mind what we've been talking about. If you're taking Xarelto once a day, and it's been 23 hours since you took your Xarelto tablet, there's probably not very much Xarelto left in your body, right? And so if they need to spend $20,000 to use Andexxa to turn your blood around, they may not need to do that, right? Because there's nothing to reverse, right? Your blood is clotting relatively close to normally it's been a while since you took your last dose. Now, opposite effect is just like, I took my dose of Pradaxa or whatever drug, 3 hours ago. Well, there's a lot of that drug around, right? And if they need to get you to the surgical suite, neurosurgery needs to go in and stop the bleeding in your brain, then they may opt to use one of these reversal agents. And they've got them there available that they can do that. So now to get to Leslie's question, is there anything new coming along? So there was a drug that we've been hearing about for many years called Seraperitag or something like that. It was like super hard to say. And, it was supposed to reverse almost any type of anticoagulant drug. It would reverse almost anything that you see on this table here. But I've not heard about that drug for a long time. And I think it's just sort of with the drugs that we've got available, I just don't, I think that a pharmaceutical company realized that these drugs rarely get used, and there's already drugs that we know work. So why, there's just really no room for another drug to come in. So I find it unlikely that you're probably going to see any more development in this space. The reversal agents are there for the drugs that we have.
So this, what you see here is what you get.
I think it'll be that way for years. Yeah.
Okay. And so for those of us that are on Xarelto and Eliquis, the primary is Andexxa.
Yes. Yep. Now, let me just say that these 4-factor PCCs, there is some indication. Now, there haven't been like very, carefully thought out trials, but before the reversal agents got here, and remember, some hospitals don't stock these just because of, they're very unlikely to use them, and it's an expense to have them have such an expensive drug sitting around on their shelves. So people would come in with, bleeding that needed to be reversed, and they tried using these 4-factor prothrombin complex concentrates, so Kcentra, and it appears as if they actually do help control bleeding. And so I'm aware of there's some clinical trials where they're actually going to compare the Kcentra to the reversal agents and see if there's any difference between the two. So, you could actually either get Andexxa or Kcentra to help manage your bleeding.
Mm-hmm.
Hey, Dan, can I ask you just a quick question about Andexxa? Because I see this a lot in the support groups talking to patients over the last couple of years. They would feel a lot better if they knew that their hospital did carry it, right? Can they call the hospital and just say, hey, I've had blood clots, I'm worried about bleeding, do you carry Andexxa? They can find that information out, right? I think they used to have a map. Andexxa used to have a map that showed all the hospitals that had it. I don't know if that's out of date now.
Yeah, for sure. I'm a pharmacist, right? So I just call the pharmacy and say, hey, is Andexxa on your formulary? So the formulary is the list of approved drugs in a hospital. I think most of your bigger like hospitals, like here in Salt Lake, it'd be the University of Utah Hospital or Intermountain Healthcare. The big hospitals where a lot of trauma and a lot of people are going to get referred in, they're very, very likely to have that drug on their formulary. But if you go, down to where I grew up, 2 hours from here to Sanpete Valley Hospital, right? There's like 22 beds in that hospital. It's just like unlikely that they're going to have that drug on the formulary.
Yeah.
If you need it, they're going to life flight you up here to Salt Lake so you can get the drug.
And that was a comment from some of the folks tonight that are in rural areas. They probably don't have access to the reversal agents.
Yeah, it's true. It's unfortunate, but it's just one of the realities of, trying to make wise uses of the resources that we have, to provide healthcare to people is, a very expensive, and I'm kind of really, hopefully this won't come back to bite me at some point, but I get frustrated with the pharmaceutical companies, to put such a cost on that drug. And some of you who are taking warfarin, so good old vitamin K, right, which you can get from some spinach, or you can, drink some Carnation Instant Breakfast, or drink a can of V8 juice, or some Ensure. There's lots of ways that you can get vitamin K, but the prescription vitamin K pill called Mephiton, right, the drug company that has the exclusive rights to that drug, they have jacked up the price so high that if we prescribe a pill for people and it's not covered by your insurance, you're going to pay $60 for one tablet of vitamin K. Can you believe that? I mean, that is almost unconscionable, right? And so we've actually had this happen, where we will say, oh, we need your INR's 12 and you got a bloody nose, let's get you some vitamin K. And they go down to the pharmacy to pick it up and they're like, oh, that's $80 for one pill. And so, we've sort of gotten away from even messing around with that anymore. We'll just tell people to, can you go down to your vitamin store, your GNC, and get some vitamin K over the counter, because it works just as well. And then they might have to take a few extra tablets of that, but, it's it's kind of disappointing when you see the
That is,
industry trying to make profit off of people like
Yeah.
that.
that is terrible. I'll tell you, I mean, I know the rural communities, this is an issue, but I live in an urban environment, and I asked about the reversal agents after I had my blood clotting episode. And I was told, well, it's something that we negotiate with the companies themselves. And sometimes we have more inventory or less inventory depending on pricing, which is not what you really want to hear as a patient.
No, no. And unfortunately, you know, this is my profession, but it's just the realities of again, you know, trying to predict, you know, what drugs you need to have around, and because even if it's sitting there on your shelf, you know, it's an expense, and especially if it goes bad, because it never gets used. So,
Okay, so this is what we have. Do we have some more slides to share with the audience tonight?
I think
Otherwise,
that's it.
my goodness, that was, I learned so much from your presentation. Thank you. And we have a ton of questions that we want to try to get through some of these. So we realize we won't be able to get through everyone's questions. I apologize for that. But Jim, perhaps we could take a few minutes with you and we could throw some to you.
Let's do rapid fire here.
Love
Try to
it.
get
I like
through as
that.
many as we can.
So Todd, we'll just ping pong back and forth.
Sure.
I'll jump in first. Can a low dose of vitamin K be used in Coumadin users when their INR is above 1.5 and they need surgery in the next day or so?
I've seen that done. Yep, I've seen that done. So you know, you try to hold enough doses, but then you check an INR the day before and the INR is still too high. Yep, you can take a low dose of vitamin K and try to make sure you don't have to, you know, you've just spent the last 24 hours on the toilet getting ready for your colonoscopy, and now, you know, your dang INR is too high. You don't want to like go through that whole thing again. So yeah, that's an option.
Okay.
Dan, there's a difference between 10 milligram and 20 milligrams Xarelto. We're told we don't have to have food in our stomach with the 10 milligram, but we should have food intake with the 20 milligram. Why is that? How does eating affect that?
So it's absorption of the drug. So with the higher dose of Xarelto, you need some fat content in there just to help the drug be absorbed and achieve reliably the amount of drug in there. With the lower dose, it's sort of a dose related effect. It's not needed. So
do you have any calorie recommendations as far as like how much would be effective?
What we usually encourage people to do is take it with the biggest meal of the day. If that's breakfast for you, take it with breakfast. If it's most people, that's dinner. And so a lot of people take it at dinner.
I think that's why Xarelto says take it with your evening meal, because they presume that's probably your biggest meal.
Probably the biggest meal.
Yeah.
Yep.
Thank you.
Okay. So we had somebody inquire, what if the patient is pregnant? So obviously they're limited in terms of what anticoagulant they could use, and that would also, I'm assuming, influence the reversal agent.
Yep, for sure. So most in the US, most pregnant patients are going to be taking Lovenox, right? So they're going to be injecting that. And that's just because the size of the drug is very big and it doesn't cross the placenta. DOAX can cross the placenta and then you get an anticoagulated, you know, growing baby, and we don't want that. And warfarin is a known teratogen, right? It is associated with birth defects called the fetal hydantoin syndrome. So we try to avoid warfarin in pregnant patients. So, right. So we didn't go over it, but there is a reversal agent for heparin-like drugs called protamine. With drugs like Lovenox, it sort of depends on when you took your last dose of the Lovenox, but it'll partially reverse the effects of Lovenox. But again, the drug wears off pretty quickly. And so, but yeah, you're right. It will affect them. Probably we're talking about Lovenox with pregnant.
Okay, thank you.
So does a reversal agent like Andexxa, does it have a certain shelf life? Like,
sure.
Does it?
Yep.
Okay.
Yep. All drugs do. And, you know, people may not realize this, but the expiration date on a drug is the calculated point in time when it's going to reach 90% of its potency. So there are very few drugs where if it hits its expiration date, that means it turns into a toxic drug that's going to kill you, right? But what it means is it's probably, it's reached at least 90% of its potency, and we can't guarantee it's going to produce the same effect.
Thank you.
Okay. I am on a JOAC. I'm traveling internationally. Are the reversal agents available outside the US?
I believe so. Yeah. And it's probably, it may be more likely that, because a lot of times governments are paying for the medications, in outside of the US. And so, there may be more standardization of what drugs people have in hospitals in other countries, European countries, etc.
Dan, don't you think it's a great idea for someone that's on an anticoagulant to, especially if they're going out, they're active, maybe have a medical alert bracelet, some kind of an ID tag stating the name of that anticoagulant that they're on? That should be helpful, right?
Always a good idea. And that's probably something that we forget to tell people, like when we're starting people out on there, is, make sure that there's some way to know that you're on an anticoagulant drug. It could be a wallet card, if you're really gung-ho, you get a tattoo. But I probably wouldn't recommend that. But a medical alert bracelet is a great idea.
And you're a mountain biker like I am. We were talking about that before. I was thinking about that today. I'm sure glad I have my medical alert bracelet ID on, because I was out there mountain biking. You never know what's going to happen.
Absolutely. Like, I'll tell you a quick story. It's not funny, but it's like part of my life. When I was a struggling student going to pharmacy school, one of my classmates was doing a drug interaction study with warfarin and antifungal drug. And so, like, I took a 60 milligram dose of warfarin, like one time shot, right? And then my INR got like really high, and I'm a bike commuter, right? And so it's like literally after I got done with that study, I got into this bike accident and sort of landed on my head. But I was like super grateful that, I had finished up this drug trial and the warfarin was all out of my system by the time that happened.
Thank God we have helmets, right?
Absolutely. Yeah. Please
Yes.
wear your
Please
helmets.
wear them.
Wear your helmets.
Ski, mountain bike, whatever. Got to be careful.
Yep.
Yeah, absolutely. Okay. I do want to be mindful of time. We've been on with Dan now for an hour, so I think we're close to the witching hour of saying goodbye to you, Dan. We would love to have you come back and continue this conversation. It's been amazing. I know I've learned a lot. I'm sure everybody else has as well. So I want to thank you for joining us. But before we leave, we are going to have an exit poll. And Mr. Robertson, for your 60th birthday today, would you like to lead the exit poll?
I wonder if am I talking slower because I'm 60 now? I don't think so. This is going to be my best decade. I've got something that popped up here. Let me get rid of that. Okay, here's the poll, folks. Here's your closing questions. Are you content with the level of education provided in today's webinar on anticoagulant reversal agents? Yes or no? And our final question, did today's webinar change the way you think about or approach anticoagulant reversal agents? Yes or no? Let's go ahead and answer those real quick, and I'm going to give you the results before we say goodnight. Dan, thank you so much for being here. I learned a lot. Once again, every pep talk, I take down a bunch of notes, and I've got a whole list here.
I mean,
thank you for inviting me. This has been really a great opportunity to exchange information and hear from people. So
good. So here are the results. Are you content with the level of education provided in today's webinar on anticoagulant reversal agents? 98% said yes, 2% said no. Did today's webinar change the way you think about or approach anticoagulant reversal agents? 88% said yes, and 12% said no. So thanks everybody for answering.
Yeah, that was amazing. And thanks for showing up again. Just want to remind everybody, we're not here to give medical advice. This is an educational format only, and please connect directly with your own physician if you need assistance. And with that, Dan, thank you again. Todd, happy birthday.
Thank you.
We'll see you soon.
Good night. I'll be well.
Thanks a lot.
Bye-bye.
Right. Take care.